Good morning, everybody. In the previous class of bronchial asthma, we discussed about the pathophysiological aspects, and based on that pathophysiological aspects, we tried to find out what are the various approaches for the treatment of bronchial asthma. So, what were the major pathophysiological aspects of bronchial asthma? Yeah, one was bronchoconstriction along with airway hyperresponsiveness, and the other aspects was inflammation. Yes. So these components were basically manifesting as the symptoms. So that symptom was actually the tip of the iceberg, and behind that symptom there was the whole lot of pathophysiological aspects that were involved. So bronchial asthma is not a single component disease, but broadly we can say it as a two component disease. One aspect is bronchoconstriction and other aspect is the inflammation. So we can categorize bronchial asthma drug into two broad categories. One is the bronchodilators and other is the anti-inflammatory drugs. Among bronchodilators, we have seen there are further three classes of drugs. One we have already discussed, beta 2 agonist, and then yes, antimuscarinics or anticholinergics, and the methyl xanthines. So in the previous class we have discussed about the sympathomimetics. Particularly we have discussed about beta 2 agonist and why we prefer beta 2 agonist and why we do not prefer drugs such as adrenaline or isoprenaline, that we have also discussed. In this class, our discussion will start with the other class of bronchodilator, that is anticholinergic, and we will discuss about Ipratropium Bromide, Titroprim Bromide, and why atropine. Atropine also is an antimuscarinic or anticholinergic drug, but why atropine is not so much preferred in the treatment of bronchial asthma, and why we prefer Ipratropium Bromide or Titroprim Bromide compared to atropine. Yes, that we will discuss, and also we will see, once we have discussed the advantages of Ipratropium Bromide and Titroprim Bromide, we will compare these drugs with the beta 2 agonistic, and we will see what are the advantages or disadvantages that these anticholinergic drugs have got compared to beta 2 agonistic agents. And then the third class of bronchodilator that we will discuss is methyl xanthines. So in the first segment we will cover up all the bronchodilators. One class we have already discussed in the previous class, and then in the next segment of this class we will focus on the anti-inflammatory drugs that are used in bronchial asthma. And one more aspect that I have told you, we can classify the bronchial asthma drugs into two broad categories. One is bronchodilator and anti-inflammatory, and we call bronchodilator as also relievers, and we call anti-inflammatory drugs as controllers. But there is one bronchodilator, that is long-acting beta 2 agonist, that is actually clubbed together with the controllers, because in spite of being a bronchodilator activity, it is usually given as a prophylactic agent, mostly in combination with the inhalational corticosteroids. Now let us first start with the anticholinergics. Now we all know the basic aspects related to the anticholinergics or related to the parasympathetic system. We know that smooth muscles and the secretory glands they actually receive innervation from the parasympathetic system, and they have got predominantly M3 receptor innervation. So if we block M3 receptors in the smooth muscles and in the secretory glands, what it will do, it will lead to bronchodilation. It can lead to bronchodilation apart from reduction in the secretions, along with the reduction in the respiratory secretions or bronchial secretions. And one aspect that you should remember about anticholinergic drugs in diseases where the cholinergic tone is very high and the bronchoconstriction is due to that high cholinergic tone. For example, in COPD, the bronchoconstriction mainly is due to the high cholinergic tone. In those disease, anticholinergic drugs such as Ipratropium Bromide or Titroprim Bromide have got a very good role to play, because these anticholinergic drugs, they act by blocking the cholinergic constrictor tone. Now, one more aspect through which we can differentiate anticholinergics is their site of action. Anticholinergics mainly affects the larger airways. As you can see in this picture, anticholinergics, they cause bronchodilation by blocking the cholinergic constrictor tone mainly in the larger airways. In contrast to the beta 2 agonistic drugs. Beta 2 agonistic drugs, they mainly affect the bronchiolar smooth muscles. So if you see this particular picture, the anticholinergics, they are affecting the larger airways, whereas the beta 2 agonistics, they are mainly affecting the bronchiolar smooth muscles. Now, in the previous class, I had told you about the historical aspects of the evolution of the bronchial asthma drugs. In India, Dhatura has been used for the treatment of bronchial asthma in Ayurveda for many centuries. By burning the Dhatura leaf, the patient were told to take the inhalation of that Dhatura leaf, and the patient used to get relief in their bronchial asthma attacks. But we were not exactly knowing the mechanism of action or the site of action or how exactly that Dhatura is relieving uh, uh, the bronchial asthma. When the European came to India, they saw that in Ayurveda we are using Dhatura for the treatment of bronchial asthma. So what they did, they manufactured cigarette containing Dhatura, and they started selling it as treatment for bronchial asthma. But drug derived from Dhatura or the anticholinergic drugs, if they are being used for the treatment of bronchial asthma, it was seen that though they were relieving bronchial asthma, but they were leading to various systemic side effects. those systemic side effects were unwanted side effects. So, and the one reason was that, like, atropine is a tertiary compound. It can cross the blood-brain barrier. It can lead to systemic side effect because of this particular reason. So, in 1970s, synthetic derivatives of the atropine were synthesized, and the first drug was Ipratropium Bromide. It was a quaternary ammonium compound, but it had a shorter duration of action. Then later on, Titroprim Bromide was synthesized. It had a relatively longer duration of action. So, as I was telling you, there were various distinct advantages of Ipratropium Bromide or Titroprim Bromide compared to atropine. And the one reason was because Ipratropium Bromide or Titroprim Bromide, they were the quaternary ammonium compound, and because they were quaternary compound, they cannot cross the blood-brain barrier, so the CNS manifestations were nil, and also because they were the quaternary compound, they cannot diffuse into the blood, leading to minimal systemic side effects, and they can be given by the aerosol inhalational route. And one thing that I have already told you, these anticholinergic drugs, they are very useful in the respiratory diseases which leads to bronchoconstriction, and the bronchoconstriction, if it is mainly due to the increased cholinergic tone, in those diseases these drugs have got very good role. And for example, in COPD, anticholinergic drugs are very commonly used because of this particular reason. And if you compare anticholinergics such as ipratropium bromide or titroprim bromide with the beta-2 agonistic drugs, though these anticholinergic drugs have got lesser efficacy compared to beta-2 agonistic drugs, but one advantage that these drugs provide you is that you can use these drugs in patients who are not tolerating beta-2 agonistic agents, because sometimes in higher doses, or sometimes in some patients in even in therapeutic doses, some cardiac manifestations can be seen with the beta-2 agonistic agents, or in thyrotoxic patient, they might not tolerate beta-2 agonistic agents. So in those categories of patient, you can use ipratropium bromide or tiotropium bromide. Now, if you compare ipratropium bromide and tiotropium bromide, tiotropium bromide compared to ipratropium bromide have got relatively longer duration of action. It has got approximately 24 hours of duration of action, and ipratropium bromide have got shorter duration of action, up to 3 to 5 hours. But both drugs have got delayed onset of action compared to the beta-2 agonistic agents. They have got delayed onset of action. Now the next thing that I have briefly told you, why atropine is not preferred in asthma, whereas ipratropium bromide or titroprim bromide are preferred in bronchial asthma or COPD. One reason that we have already discussed is that atropine is a tertiary compound. It can cross the blood-brain barrier, it can lead to CNS side effects, it can lead to systemic side effects, whereas ipratropium bromide or tiotropium bromide is a quaternary compound. They do not, or they cannot cross the blood-brain barrier, and the systemic side effects are very less. The other thing is that atropine non-selectively inhibits the respiratory secretion. It will inhibit the secretion of nose, mouth, pharynx, and also bronchial secretion will be inhibited. So atropine non-selectively inhibit the respiratory secretion and it dries the mucous membrane of the respiratory tract. So one aspect is that atropine is a tertiary compound, can lead to systemic side effect. Second aspect is that atropine is non-selectively inhibiting the respiratory secretion. The third aspect is that atropine will also suppress the mucociliary clearance. So all these aspects like drying of mucus secretion and suppression of mucociliary secretion or mucociliary clearance can lead to formation of mucus plug. And what this mucus plug can do, mucus plug can obstruct the airflow or airways and can predispose the patient to the respiratory infection. So that is the one aspect that you should remember, or these are the aspects that you should remember while discussing why atropine is not preferred and why ipratropium bromide or titroprim bromide is preferred. So we have seen the good aspects of these synthetic anticholinergic agents, that they produce bronchodilation, they selectively acts on the bronchial muscle, they selectively reduces the bronchial secretion without altering the volume or consistency of the respiratory secretion. They do not affect the mucociliary clearance, and because they are the quaternary compound, they have got minimal systemic side effect. So they have got advantages compared to atropine. But if you compare these compounds with the beta-2 agonistic agents, compared to beta-2 agonistic agents, they have got relatively slower onset of action. So you will get slower response with these agents compared to beta-2 agonistic agents. But the good thing is that if you combine these anticholinergic agents with beta-2 agonistics, particularly in severe asthma, you will get a very good response and a longer lasting bronchodilatory effect. And the other thing that I have already told you is that these anticholinergic agents, these are preferred in the treatment of COPD, because in COPD bronchoconstriction is mainly due to the increased cholinergic constrictor tone. Their efficacy in asthma is modest or relatively less. Now let us discuss about the third bronchodilatory agents, that is methyl xanthines. Now methyl xanthines, the name is derived from the aspect that they are the methylated derivative of xanthine, and there are three naturally occurring methyl xanthines that are found in plant. So these are basically plant derived alkaloids. One is caffeine, which is mainly found in coffee. One is theophylline, which is mainly found in tea, and one is theobromine, which is mainly found in the chocolate or cocoa. But only theophylline and its derivatives such as aminophylline are used in bronchial asthma. So originally theophylline was extracted from the tea leaf, but now they are being chemically synthesized. Let us understand the mechanism of action of methyl xanthines. Now there are various aspects through which methyl xanthines acts. One of the important aspects that you should know is that they actually inhibit cyclic AMP phosphodiesterase, and we know that phosphodiesterase is an enzyme which actually breaks down the cyclic AMP. So if you inhibit phosphodiesterase, naturally you will increase the cyclic AMP level. So these increased cyclic AMP basically leads to smooth muscle relaxation. Now these methyl xanthines basically inhibits two type of phosphodiesterase. Phosphodiesterase 3, which is present in the airway muscles, and phosphodiesterase 4, which is present in eosinophils and mast cells. So they also inhibit the release of the histamines. So the basic thing is that this inhibition of cyclic AMP phosphodiesterase, they increases the cyclic AMP level, and this increased cyclic AMP basically leads to bronchodilation. Now one question, if I ask you, if we combine methyl xanthines with beta 2 agonistic agents, will we get enhanced effect, or will uh, uh, the action of beta 2 agonistic will be synergized by adding theophylline like drug? Yes, because beta 2 agonistic drug is also increasing the cyclic AMP, and methyl xanthines, because they are inhibiting cyclic AMP phosphodiesterase, they are also ultimately they are also increasing the level of cyclic AMP. So in this way, because both of them are actually increasing the cyclic AMP, they can synergize each other action. So apart from increasing the cyclic AMP level, the other thing that methyl xanthines does is that they block the adenosine receptor. And you must be knowing that adenosine actually modulates the histamine release, and this histamine release will actually lead to bronchoconstriction. Now this methyl xanthines, they block the adenosine receptors, particularly adenosine 1 receptor, which is present in the airway smooth muscles, and the adenosine 3 receptors, which is present on the mast cell. So this blocking of adenosine receptors will actually relax the smooth muscle and also will inhibit the histamine release. But the things that we were discussing will usually happen in the therapeutic doses. But what will happen if we give higher dosage of theophylline, or if we give higher dosage of methyl xanthines? In higher doses, methyl xanthines can increase the release of endogenous catecholamine, and this increased release of endogenous catecholamine, they can lead to cardiac manifestations which can manifest as arrhythmia, and CNS manifestations which can manifest as seizures. And also in higher doses, the release of calcium from the sarcoplasmic reticulum is enhanced, especially in skeletal and cardiac muscles. Now let us understand the pharmacological actions of methyl xanthines, and just remember or just focus on the three aspects: its action on CNS, its action on CVS, and its action on GIT. And particularly with reference to CNS and CVS, try to understand what happens in normal therapeutic doses and what is happening in higher doses. And then we will also see its action on kidney, smooth muscles, mast cells. In CNS, in normal therapeutic doses, basically CNS stimulation happens and it improves the performance of the patient. It increases the motor activity. Basically, the psychomotor activity is enhanced or improved. But if you increase the doses of methyl xanthines, it will lead to nervousness, insomnia, restlessness. And if you further increase the dose of methyl xanthines, it can lead to tremor, and it can also ultimately lead to seizures or convulsions, which can be dangerous. Then, as far as CVS is concerned, in normal therapeutic dosage, it will stimulate the heart, it will increase the force of contraction, it will increase the cardiac output. But if you further increase the dose, it can lead to cardiac arrhythmia, which can be dangerous. Then in the GIT, it enhances the secretion of acid and pepsin. In kidney, it has got mild diuretic effect. It increases the renal blood flow. It increases the BMR. In the smooth muscle, it leads to relaxation. It leads to bronchodilation. Biliary spasm is relieved, and in the mast cell, it inhibits the release of histamine that we have already discussed. So just remember, methyl xanthines is a narrow therapeutic index drug. It has got a very narrow therapeutic window, and its therapeutic effect is actually manifested in that particular narrow therapeutic window. Beyond that, you will start noticing the adverse effects, particularly pertaining to the CNS, CVS, or GIT. So you have to closely monitor the plasma concentration of the drug if the patient is being prescribed this particular class of drug. As you can see in this particular picture, the therapeutic effects is usually being manifested in the range of 5 to 20 microgram per ml. And if the plasma concentration is raised beyond 20 microgram per ml, you will start noticing the various adverse effects pertaining to the GIT, CNS, CVS. So in very higher plasma concentration, it can lead to convulsions, arrhythmias, and even death. And because of this particular reason, nowadays it is not a very preferred agent for the treatment of bronchial asthma. The other thing related to its pharmacokinetic is that it follows a saturation kinetics. And if I ask you what is saturation kinetics, yes, on therapeutic doses or in the lower doses, it follows the first order kinetics. But on prolonged usage or prolonged dosage or higher doses, its order of kinetics changes from first order kinetics to zero order kinetics. So that is dangerous, because even a small increase in dose will lead to very disproportionate increase in plasma concentration. And what we are noticing here, methyl xanthine is a narrow therapeutic index drug. So the therapeutic effect is usually manifested in that particular range of 5 to 20 microgram per ml. If the plasma concentration increases above 20 microgram per ml, you will start noticing the CNS adverse effects, GIT adverse effects, CVS adverse effects, and it can also lead to death of the patient. So as far as its pharmacokinetic is concerned, I have already told you that as far as its metabolism is concerned, it follows saturation kinetics. Its order of kinetics can change from first order to zero order on higher doses. As far as its distribution is concerned, it crosses the placental barrier and it is secreted in milk, so it cannot be given in the pregnancy or lactation, and its elimination rate actually varies with age. The interesting thing is that in adult the T half is around 7 to 12 hours, whereas in children the elimination is very faster, and in children the T half is in the range of 3 to 5 hours, whereas in neonates or in premature infants the T half is prolonged to 24 to 36 hours. So clearance actually varies with age as far as this particular drug is concerned, and it is highest in young adolescents and it is lower in older people as well as in neonates. And because of this particular reason you need to reduce the dose in the elderly patients, and also you need to reduce the dose in the neonates. Now, as far as drug interaction is concerned, methyl xanthines, these are basically metabolized by the cytochrome P450. Now, if you prescribe enzyme inducers such as phenytoins, rifampicin, phenobarbital, they will increase the metabolism of theophylline, and ultimately you will get the less effect of theophylline if these drugs are being prescribed along with the theophylline. Whereas if you prescribe enzyme inhibitors such as erythromycin, ciprofloxacin, cimetidine, these drugs will decrease the metabolism of theophylline, and ultimately they will, because they are decreasing the metabolism of theophylline, they will enhance the effect of theophylline. And one other thing that we have already discussed is that theophylline increases the effect of other drug. One important drug that we have discussed is sympathomimetics. Have you understood how theophylline enhances the effect of sympathomimetics or vice versa? Because both are actually increasing the cyclic AMP level. Now, why use methyl xanthines? Nowadays, because of various drawbacks associated with methyl xanthines, particularly related to its pharmacokinetic aspects, because of its being a narrow therapeutic index agent, these drugs are not a first line agent for the treatment of bronchial asthma. It can be considered as a second or third line drug in the treatment of bronchial asthma or COPD, and it is only recommended when you are not getting the response from the first line agents or the second line agents. Then you can go ahead with this particular drug. So it is not recommended as a first line drug in the treatment of bronchial asthma. Now we have discussed about bronchodilators. Now let us move on to the second segment of this class, and in this segment we will discuss about anti-inflammatory agents, and the important ones are the Leukotriene antagonist such as dapiroleucast, monteleucast, mast cell stabilizers such as sodium chromoglycate, and most important are the corticosteroids such as inhaled corticosteroids or the systemic corticosteroids. Now let us first start with leukotriene antagonist. we all know that the leukotriene B4, which is acting through the leukotriene B4 receptor, is a potent neutrophil chemoattractant, and it is a potent mediator of inflammation. Whereas the cysteine leukotrienes such as leukotriene C4, D4 and E4, these are the potent mediator of bronchoconstriction, mucus secretion, hyperresponsiveness and eosinophilia. And what we are noticing in this particular pathway is that the 5-lipoxygenase enzyme is involved in the formation of leukotrienes. And if you talk about the cysteine leukotrienes, these are acting through the cysteine leukotriene 1 receptors. Now, there can be two aspects to the treatment of bronchial asthma by modulating the leukotriene. One is you directly inhibit the 5-lipoxygenase. Okay. The second aspect is you inhibit the cysteine leukotriene 1 receptor. So you can inhibit 5-lipoxygenase through a drug known as xylitol, and you can inhibit the leukotriene receptors or cysteine leukotriene 1 receptor by using drugs such as gefapixant or montelukast. Okay. Now let us see the advantages and disadvantages of these two drug classes, that is 5-lipoxygenase inhibitor and cysteine leukotriene receptor antagonist. Now 5-lipoxygenase inhibitor, these are also known as leukotriene synthesis inhibitor. Why these are known as leukotriene synthesis inhibitor? Because if you inhibit 5-lipoxygenase enzyme, it will ultimately inhibit the leukotriene synthesis. Not only it will inhibit the synthesis of leukotriene B4, but it will also inhibit the secretion of leukotriene C4, D4. So it has the potential to prevent all leukotriene induced response. But the problem with this leukotriene synthesis inhibitor drug such as xylitol is that they lead to liver toxicity. They can elevate the liver enzyme, and because of this particular reason you need to frequently monitor the liver enzyme, and because of this particular reason of liver toxicity, this drug has been withdrawn or has been banned in many countries. But as far as efficacy is concerned, its efficacy was as good as we can say montelukast. But because of this liver toxicity problem, xylitol is not very frequently used. Now let us move on to the second category, that is leukotriene receptor antagonist. These are selective reversible antagonists of cysteine leukotriene receptor. And in contrast to the 5-lipoxygenase inhibitor, their toxicity is relatively low. Very rarely you can notice this Churg-Strauss syndrome, which can manifest as systemic vasculitis, but that is very rare. And these leukotriene receptor antagonists, they have got anti-inflammatory action, but as far as anti-inflammatory action is concerned, they are less efficacious than the inhaled corticosteroid, but they actually potentiate the corticosteroid action, and they have got glucocorticoid sparing effect. So where to use this particular drug class? As I have told you, 5-lipoxygenase inhibitor, because of its liver toxicity, it is not very commonly preferred. So you can look for drugs such as montelukast or gefapixant, which are relatively safe. So you can use these drugs in mild to moderate bronchial asthma as an alternative to inhaled glucocorticoid, because they have got anti-inflammatory action, though their anti-inflammatory action is less efficacious than the corticosteroid or the inhaled corticosteroid, but they can be used as a prophylactic therapy as an alternative to inhaled corticosteroids. And if you are particularly worried about the adverse effect of inhaled corticosteroid, particularly in children, you can go ahead and you can use leukotriene receptor antagonist. And if at all you have to use inhaled corticosteroid in those categories, also you can go ahead and you can use leukotriene receptor inhibitor, because what these drugs do that they actually reduces the dose that is required with the inhaled corticosteroid, or even with the beta 2 agonistic agents. Or they can be combined with the glucocorticoid, they can be given along with the glucocorticoids because they have got additive effect. And also, as I have told you, along with leukotriene receptor antagonist, you can use low dosage of glucocorticoids. Now let us move on to the second class of anti-inflammatory agents, that is mast cell stabilizers. Now the name itself is very much clear, mast cell stabilizer. So they stabilizes the mast cell. So if you stabilizes the mast cell, you will inhibit the degranulation of mast cell and other inflammatory cells. So you are ultimately restricting the mediator release by stabilizing the mast cell. And they stabilizes the mast cell by preventing the transmembrane influx of calcium. They also prevent the chemotaxis of eosinophils and neutrophils. Now there is one drug apart from sodium chromoglycate and nedocromyl. There is one drug, interesting drug, which is known as Ketotiphan. Now Ketotiphan has got dual mechanism of action. It has got H1 antihistaminic action along with sodium chromoglycate like action. So where we can use mast cell stabilizers? Naturally, because they are not reliever, they are controller, they can be used for a prophylactic purpose, and when taken regularly for prophylaxis, they actually reduces the need for bronchodilators or even the corticosteroid therapy. And they should not be used in acute attack. They are only used for prophylaxis of chronic asthma and for prophylactic purpose. If if patient is prone to suffer from attack of asthma during particular season or during particular weather, he or she can start this mast cell stabilizer 2 to 4 weeks before when the symptom is actually expected. And it is safer to be used in pediatric population. They can also be used in allergic rhinitis and allergic conjunctivitis. But remember, they are ineffective in acute attack. They do not have any bronchodilatory action, and they are available as inhalers. Now let us move on to the last class of or last segment of this class, that is corticosteroids. Corticosteroid will be discussed separately in a separate class while we are discussing endocrine, but here only the relevant aspect will be discussed. As far as its mechanism of action is concerned, the corticosteroid basically inhibits the phospholipase A2, and this inhibition of phospholipase A2 will decrease the synthesis of arachidonic acid and prostaglandins and leukotrienes, and they also decrease the inflammatory cells in airways. So basically glucocorticoids are used for a prophylactic purpose because of their anti-inflammatory effect, and they suppress inflammatory response to all noxious stimuli, and they reduces the cardinal sign and symptoms of inflammation. Now you cannot use corticosteroids or inhale corticosteroids in the treatment of acute asthma, or for the bronchodilatory purpose you cannot use. First thing is that they do not have any bronchodilatory action. Second thing is that they need a longer time to for its actions to appear. Their effect usually attained after 2 to 4 weeks. They have got delayed onset of action. So they are mainly used as controllers for long-term stabilization of the bronchial asthma symptoms because of their anti-inflammatory effect. And they can either be used alone, or preferably they are combined with the long-acting beta-2 agonistic agents. So steroids are used if patient has to use the short-acting beta-2 agonistic more than 2 times in a week for a symptomatic relief. Usually, we will discuss just after a few minutes. In bronchial asthma, we follow a stepwise pattern for the treatment of bronchial asthma. In step 1, usually what we do, we give, if you get any attack of bronchial asthma, as and when required, you can use this short-acting beta-2 agonistic inhalers. But if patient start to suffer more than 2 attacks per week, then you cannot go ahead only with the short-acting beta-2 agonistic agents, because anyway short-acting beta-2 agonist, if these are used for a very longer period without any gap in the treatment, there will be down regulation of receptor and you will not get the desired benefit on a long term. So in bronchial asthma, usually we prescribe, as far as corticosteroid is concerned, we prescribe inhaled corticosteroids such as beclomethasone, budesonide, fluticasone, mometasone. But you have to be careful about inhaled corticosteroid adverse effect, though they are very safer compared to the systemic corticosteroid, but still they can lead to the local side effects. The important one is the oropharyngeal candidiasis. But the local side effect can be reduced with the use of spacer or by frequent rinsing of the mouth. The possible systemic side effect of inhaled corticosteroid are similar to that of the oral corticosteroid, such as decrease in growth velocity, cataracts, bone fracture, osteoporosis. But compared to the systemic corticosteroid, the chances of these side effects appearing with the inhaled corticosteroid are relatively less. Now, one thing that you should remember, when to go for systemic corticosteroid and when to go for inhaled corticosteroid. Systemic corticosteroid will be required if, say for example, a patient suffering from status asthmaticus come to an emergency. Status asthmaticus is also known as acute severe asthma, and it is treated on an emergency basis, and it is treated in an emergency, and you need to save the life of the patient, because if it is not treated on an emergency basis, the patient might die. So by the normal treatment protocol, this status asthmaticus cannot be treated. So in that particular case, because you have to save the life of the patient, you have to opt for the systemic corticosteroids such as hydrocortisone or prednisolone, along with the other agents. The other aspect wherein systemic corticosteroid can be used in chronic bronchial asthma, if you are not getting desired response from the previous drug regimen, and the frequency of symptoms is progressively increasing. In that case, you can go ahead with the systemic corticosteroid for a shorter period, and then you can taper the dose, and based on case to case basis you can take a decision. Inhaled corticosteroid should be considered for adult or children with any of the following feature. As I have told you, if the patient is using a short-acting beta-2 agonistic agent and for more than 2 times per week, then you have to go for the inhaled corticosteroid. Or if patient is symptomatic more than 2 times per week or more. Omalizumab. This omalizumab is actually an antibody to an antibody. Now, what is this antibody to an antibody? Omalizumab is a recombinant DNA-derived humanized IgG1 monoclonal antibody, and it actually binds to the IgE. Okay, so it is an IgG1 monoclonal antibody, and it actually binds to the IgE. So and what it does, it actually inhibits the binding of IgE to the IgE receptors on the surface of mast cell and basophils. So it actually inhibits the release of mediators of the allergic response. But usually it is not used in acute cases. It is usually used only in the resistant cases, but the cost is very high, and cost is one of the factors that you should take into consideration. Now let us just discuss the last aspect of bronchial asthma management. As I have told you, bronchial asthma usually is a stepwise management is preferred. In step 1, you can prescribe the short-acting beta-2 agonistic agent as and when required. Okay. In intermittent cases, can you name any short-acting beta-2 agonistic agents? Salbutamol. Now, if patient is not controlled from using short-acting beta-2 agonist, or he or she is symptomatic for more than the attack is occurring more than 2 times per week, you have to go to step 2. Step 2 is actually mild persistent bronchial asthma. In step 2, you have to go for the low dose inhaled corticosteroid. Okay. Or if you are not want to prescribe, if you don't want to go for the corticosteroid or inhaled corticosteroid, the alternatives are the mast cell stabilizer such as sodium chromoglycate or leukotriene receptor antagonist, or rarely you can go for the methyl Gianthenes. Then in the moderate persistent, or in the step 3, the preferred agent is the medium dose inhaled corticosteroid. See, in a step 2, you have started with the low dose inhaled corticosteroid. In step 3, you have moved to the medium dose inhaled corticosteroid. Or if you don't want to increase the dose of inhaled corticosteroid, what you can do, you can go ahead with low dose inhaled corticosteroid, but you can add long acting beta 2 agonistic agents. Okay. The other alternative is in this step 3, along with low dose inhaled corticosteroid, rather than going ahead with the long acting beta 2 agonistic agent, you can add leukotriene receptor antagonistic agents, or rarely you can go ahead with theophylline. Then step 4, preferred is the medium dose inhaled corticosteroid along with the long acting beta 2 agonistic. Step 5 is high dose inhaled corticosteroid along with the long acting beta 2 agonistic, and consider omalizumab for patients who have allergies. Then step 6 is high dose inhaled corticosteroid plus long acting beta 2 agonistic plus oral corticosteroid or systemic corticosteroid, and you can consider omalizumab if patient have allergy. And then comes the status asthmaticus. The treatment protocol of status asthmaticus I will discuss just after this slide. And see, this is not only a step up approach, you can also move down. So step up if needed and step down if possible. Okay, based on the control that you are achieving with the patient. Step down if possible, and asthma if asthma is well controlled for at least 3 months. Now the last comes the status asthmaticus. Now status asthmaticus is an acute severe asthma, and in status asthmaticus the patient will not respond to the standard treatment protocol that usually is recommended, and patient will suffer from the two major aspects of bronchial asthma pathophysiology. There will be severe airflow limitation and there will be severe airway inflammation. So to relieve the airflow limitation, you have to naturally go for the bronchodilatory therapy, but here you have to start with the nebulized form. You have to give nebulized salbutamol plus Ipratropium Bromide, and intermittent inhalation with oxygen should be given. Okay, we have already seen that if the beta 2 agonistic agents are combined with the anticholinergic agents such as Ipratropium Bromide, you get a synergistic effect or you get a better effect. If required, you can go for systemic salbutamol or terbutaline. You can give intramuscular injection or subcutaneous injection of salbutamol or terbutaline. And to take care of the airway inflammatory part, you have to give systemic corticosteroid such as hydrocortisone. There is limited role of antibiotics. There is limited role of the methyl Gianthenes. Antibiotics might be required if patient is suffering from fever or any other chest finding is there. In severe cases, based on clinical judgment, the non-invasive ventilation or mechanical ventilation can be required. Treat hypoxemia if present. So this is how the bronchial asthma, and in this particular case the status asthmaticus, should be treated. So we have discussed the whole aspects related to the pharmacology of bronchial asthma. We started with the pathophysiological aspects, then we discussed what are the various ways to treat bronchial asthma. Then in the previous class we discussed about the beta 2 agonistic agents and what are the various bronchodilators. In this class we discussed about the anticholinergics, we discussed about methyl Gianthenes, then we discussed about the anti-inflammatory agents. In the anti-inflammatory agents, we discussed about the leukotriene receptor antagonist, we discussed about mast cell stabilizers, we discussed about corticosteroids, particularly inhalational corticosteroids. Then we also discussed about the stepwise treatment of bronchial asthma, and in the last we discussed about the treatment of status asthmaticus. So with this we have covered the discussion on bronchial asthma. Thank you.